When the medication gets out of the vein and into the muscle, it hurts a lot, and it can detriment. It can really affect how wide the vein is. Hey guys, welcome to the Nurse Multiverse podcast. My name is Gene. I've been a nurse for about 15 years, and what we're going to be looking at today is the concept of IV therapy in the context of heart failure. Okay, so first we answer, what is IV therapy? IV therapy is the planned vascular access throughout the disease progression. What I mean by this is heart failure is separated into four categories. Category A is just at risk. If you have any diseases that could potentiate you getting heart failure. Stage B, it's pre-heart failure, meaning that your EF is 40% or less, but without any symptoms. Stage C would be heart failure with symptoms, which require medication therapy. And then finally, stage D, which is the end stage of heart failure, which will require implantable devices like an LVAD, an RVAD, or transplantation of a heart. All right. So when you're an IV therapist, your goal is to prevent vascular exhaustion. What I mean by this, vascular exhaustion is typical patient starts with the disease maybe at age 30, maybe at age 40. And as the disease progresses, it requires more time spent in the hospital, more time doing procedures. Every time that the patient gets admitted and discharged, you're going to be using a certain amount of their vasculature. If you don't plan this appropriately, patients can get to stage D of heart disease and have potentially no access anymore in the arms, which is going to require for them to have a central line port. If you put a central line port in the patients, the risk for infection becomes higher, which can impact on overall outcomes.
Can we back up a little bit and can you stage A, right?
Mm-hmm.
Just have like a better idea.
Mm-hmm.
So stage A you said was at risk patients.
Right? At risk patients that have hypertension.
By the way, all this is staying in.
Okay, yeah.
Like yeah. Off. Okay. All right. So at risk patients. So those patients would be.
Those patients will be diabetics.
Okay.
Hypertensives, hypercholesterol, any kind of disease that is going to put a strain in your heart, basically, and it's a risk.
And then, so on stage B, right? Can you break that down?
Yeah, stage B will be pre-heart failure, meaning that you have an EF, ejection fraction, of 40% or less.
So what would that be? Because I know, like, if like all the nurses and all the people in the medical field that are listening to this, they understand what that is. But let's say that like someone like me is listening.
Ejection fraction is basically how much your heart is pumping out to your general system, and that can be affected if you have hypertension. Then it makes more difficult for the heart to push that blood out on the general system, which in turn makes the cardiac muscle grow. This is what happens and what makes the heart to be enlarged. And as the heart gets bigger, what happens is it becomes less strong. It cannot pump out as much. So it's a progressive situation. Like I said, at A, you are at risk because of your previous diseases. On B, the ejection fraction is below a certain threshold, meaning that your heart can pump only a certain amount. And at this point, it might be treated with medication or not. But the main differentiation between stage B and stage C is that in stage C, you start having signs and symptoms of heart failure, which include syncope, which is when you faint, or dizziness, inability to do strenuous exercise, and other symptoms like that. At that point, most patients are on a medication regimen, either one or two medications, maybe three, until they go through the next stage, which is stage D. At that point, the symptoms are happening even at rest, meaning you're short of breath even if you're sitting down. You can't sleep flat on your back because of the shortness of breath. And at that point, the medications become less effective. So when that happens, you need to implant a device that's going to lower the amount of blood that the left ventricle is trying to push up in order for the heart to have less work. And
so that's you said it was stage D, right?
That's stage D. That's the end stage.
Okay.
Usually with that, the only thing that fixes that is either an implantation of a medical device, like an LVAD, for example, which is a pump. What it does is it drains your left ventricle and it reroutes it, kind of like a turbo system. Okay. And that makes the heart slightly less empty and has to do less work to push the blood out to the general system. Then the other choice when you are at stage Z is getting a heart transplantation. So the IV therapist, what that person is going to try to do is intervene as early in the disease stage as possible, starting from stage A, when a patient is at risk. If you start planning their vascular access, meaning what IVs you put in, for what reason, it requires a map of the patient's arms, like abenography, in order for you to plan their vascular access to prevent vascular exhaustion. Vascular exhaustion is basically the inability to start IVs peripherally. When that happens, the patient then needs a port, a medication port that either goes in the femoral veins or IJ, which is the internal jugular vein. The problem with these devices is that the incidence of infection, it's higher the more that you get them. And the vasculature is only going to take a certain number of these devices to put in. Every time you put a device in a central vein, that actually starts because of the inflammation of the vein, because you have a foreign object there, you start getting vein stenosis, meaning it's not as wide every time that you put in a central line in that way. People with catheters centrally implanted have a way higher mortality rate, life expectancy over about 5 years once you start getting these because of the frequent infections. So if you are able to plan the patient's vascular access from the beginning of the disease, then you can stem the use of central lines. You will use less central lines throughout the patient's life.
Your experience is, or the area where you've your work, it's the area of your work is the planning, the vascular lines.
Yes.
Okay.
So that's what IV therapy is.
Okay.
Basically, is the management of vascular devices throughout the disease. It can be adapted to any disease. We're talking right now about heart failure, but it can be adapted to renal failure. It can be adapted to pulmonary hypertension. It can be adapted to just geriatric care. It's kind of like a different treatment every time, but the goal is always to reduce the incidence of central lines and therefore reduce the incidence of vascular exhaustion and infections. Okay. That's the whole point of treating people this way.
And can you give a little backstory on how long you've been doing this and why you got into it? That way it helps the listener understand.
So we started doing this in Houston in the Heart and Vascular Center about 2016. We were noticing that a lot of our patients were our CLABSI, which is a central line associated bloodstream infection, which is what you call central line infections. You call it CLABSIs. And we were noticing that our incidence was pretty high. At the same time, we started looking and we saw that we were using central lines extensively. The ratio of people that had central lines in the unit was very high, which leads you to having more infections. It's kind of like, think of the disease process like a tree. The more central lines you have, the more infections you're gonna have. It doesn't matter how perfect the care is, the quality control. It's just having central lines is gonna lead you to having more infections. So between the critical care team and the nursing team, we came up with a set of rules that we differentiate when the patient's going to get a central line versus when they're going to have a vascular assessment to decide, basically, start with peripheral IVs, ultrasound placed, specific areas that you've already studied in the patient anatomy that's going to provide the most bang for buck, meaning let's use the minimal size of IV catheter that is going to allow us to treat the disease at that time. Okay, so when you get involved with the patient,
you can move the mic back and forth, by the way, like however you're comfortable.
Yeah, no, this is good. So the earlier you get involved in the patient's disease, doesn't matter what disease. We're covering heart failure now, but the earlier that you get involved as an IV therapist in the disease progression, you're going to have more tools and more options. The more you wait or the later this gets started, the less options you're going to have. So typically an IV therapist is going to get involved once you have your first visit to the doctor. It could be because you're at risk and you are preemptively going to a cardiologist, which should be like the standard. But normally what happens is people have a heart attack or they have a syncopal episode or they go to the regular doctor and the doctor hears something, a sound over their heart that is indicative or of a mechanical problem in the heart. And that's how most heart failure gets diagnosed. We have a problem with prevention. People don't go to the doctor until they start feeling bad. And if you look at the disease progression, if you go to the doctor once your symptoms start, you're already at stage C. So
I'm gonna pull that up on the screen again so they can see it.
Yeah. So if you are, which most people do this, and it's something that education has to be done in order for people to understand that they have to go see the cardiologist after you're 40, get checked out.
If you're below 40, maybe like once a year, you'd say, or
no, if you're below 40, at that point you got to look at your
show up, right? Like if you do a yearly physical, some of that stuff will show up, right?
Yes. If you are below 40, but you have a pre-existing condition, like you are diabetic, you have hypertension, that cues you in to go see a cardiologist at least once a year.
Okay.
Or every couple of years, or at least ask more questions when your general practitioner is looking at you. Be more educated and ask more questions, because it's a lot better to go and start medication early than to wait for symptoms to happen and start medication late. Because the heart, your body will compensate a huge amount. That's why they call it the silent killer.
Okay.
Your heart will compensate until you no longer can deal with this. And sadly, that's how most patients get started. So you have a heart attack at 40, 45. At this point, you're at stage C, which means that you're having to take medications, and you already had a temporary device placed, like an intra-aortic balloon pump, which technically...
What is that?
An intra-aortic balloon pump, what it does is the same that an LVAD does. It's just when you have an LVAD, you can go home.
What is...
An LVAD is a left ventricular assist device.
Okay.
Okay. So basically, all of these devices, what they're designed to do is to take the workload from the left ventricle and decrease that load so the heart can pump.
All right.
The more that the left ventricle is hypertrophied and full of blood, the less effective your ejection fraction is going to be.
And for the average,
That's what we're doing
person,
this for the average.
what does the left ventricle do as far as the cardiovascular function?
Okay, so the left ventricle is the main chamber of your heart, and what it does is it pumps oxygen-rich blood into your aorta in order for it to go systemic. All right. So we got a left ventricle and a right ventricle. The left ventricle in heart failure usually fails first, meaning the left ventricle starts getting big, can't push anymore. You have an arrhythmia or a cardiac event. Within stage D, you go from lesser symptoms to worse symptoms. First, your right ventricle craps out, usually. You don't do nothing to take care of it, or the disease starts progressing further, and then your right ventricle becomes involved. Once the right ventricle becomes involved, the disease progresses pretty fast, which, it requires for you to go to the hospital, and you basically had to stay there until we either put an implantable device or we get you a heart transplant. So yeah. Again, the earlier that you have an IV therapist start controlling what access you have and for what those access are, then the longer time you're going to have and the more options you're going to have when you hit stage D. All right. So you have a heart attack at 40, let's say. And at that point, the doctor puts you on one medication. You have once you have a heart attack, the doctor's going to be following you at least once a year, depending on how your disease is progressing, but multiple times a year, for most people. That will be at stage C. Okay, so some people, depending on how the disease is and how it's progressing with them, are going to require the temporary implantable device, like the balloon pump that I was talking about earlier. They're going to require that temporary. They're going to recover heart function and maybe go home. As the disease progresses, that outcome becomes lesser and lesser, and it starts going into the chronic devices like an LVAD that I already spoke about. So it's really important for the IV therapist to get involved early. If you are receiving antibiotics, for example, you're going to require a specific type of vascular access. It's going to maximize how much vasculature you use in relation to what the antibiotic does to your body. If, on the other hand, you require medication to thin your blood, that also changes what vascular access you're going to use. And so on and so forth. You can divide and decide what access you're going to have all the way to a central line. And I think that concludes pretty much what IV therapy is and what it means. It's relatively a new term because we as a society, we don't really do much prevention. We do correction. But if you look at all the numbers, prevention is always going to give you better outcomes. And a big part of the patient quality of life or the prognosis of how long they're going to live, it's directly related to their vasculature and how healthy you can make it be.
Okay. Do you have anything else you want to share on this?
No. Any questions I can answer?
Sure.
We can talk about.
Yeah. No, let's do it. So I have a couple of questions. How do you found this? Like, what were you talked about? You were working at the cardiovascular unit, right?
Yeah. So basically,
Like,
Um,
how did you realize that all like these diseases or these infections were coming from the like the you were saying the IV therapy lines, right?
mhm.
That's how like what the that's very interesting.
Well, yeah. So we started looking when we started this intervention program, we were noticing a high incidence of central lines in the unit, leading to a high infection rate. And how can we stop this? When you use, for example, ultrasound technology to start IVs, you can select the vein that works best.
Normally, that's not the way it's done.
Normally, you get IVs put blind. Now things are changing.
But that was like the history of this was that you just pick a vein and an IV goes in there. Like usually, what vein is like? It's
Usually, it's your AC,
okay,
which is the vein that goes right here. And that's the first vein that gets used or overused.
Okay.
Therefore, you lose at first, and then you don't. What happens when you put IVs on veins is a phenomenon called
for the by the way for the people that are listening, which was the vein? Like if somebody's just listening on
your
audio,
antecubital vein,
which would be like on the like what part
on
of
the eye of your elbow.
On the eye of the elbow, so not like on the opposite side of the elbow.
On the inside part, right behind. So when you start putting vascular devices in people, starting with the normal, humble IV, a phenomenon start occurring, which is vein stenosis, which is an inflammation of the vein layers because you're putting a foreign object there, and vein shattering. Vein shattering means you have a AC vein, you put an IV there, something happens, the IV infiltrates or stops working for whatever reason, and that vein starts using what is the term? Anyway, that vein becomes smaller, and it starts developing capillaries. Capillaries are the little tiny veins.
Was it like retracting? Is that like
no? It's more like it doesn't necessarily divide.
Okay. No, when you're saying it becomes smaller, it contract.
It starts forming other canals to get the blood up to your heart.
Okay.
All right, and those canals are very small,
so
you can't do an IV on them.
Okay.
So the more that I access your neck, your arm, every time you put a device there, you're gonna lose some of your circumference. Okay. All right. So every time you do it, you can't avoid this. This is gonna happen. So the way you treat this is, back in the day, prior to 2015, the patients, this was a federal FDA recommendation, which peripheral IVs had to be changed every 4 days, whether they were working or not. When you put a blind IV, it might work for up to a week. If it's in a really good spot, maybe 2 weeks, but not more than that. When you use an ultrasound IV, selected appropriately, and barring any complications the patient might have, you can basically have this IV for up to 30 days. My record was 90 days with one IV on a patient.
Wow, that's great. Now, a quick question there. What would be the main? I know you're explaining it, but what would be the main difference between an ultrasound IV and a blind IV? Like, how's the process different?
So basically, the way that I like to explain this is like you're a plumber. If you're a plumber and you are having issues with drainage, you got to look in the plumbing system to see what's happening with it. If you're not able to see exactly where an obstruction might be, paper, whatever, if you're not able to see where that is, then it's going to be harder for you to determine if you need to replace the whole piping or what. So when you're doing an ultrasound IV, you're looking at the veins in real time, directly, and you can avoid areas of stenosis, which is narrowing. You can avoid veins that are not long enough. or veins that are not wide enough for the therapy. Because depending on what medication you're going to be giving the patient, that changes the size of the cannula that you're going to put in there. So in this way, you can plan the optimal angle for the catheter to go in. If the catheter, for example, you have your vein.
Let me show the screen so that. All right. Go ahead.
So you have your vein right there. Blood flow is going. So blood flow is going there.
So
this
now,
is,
as you draw, please,
Mhm.
try to give a description for anybody that can be just on audio.
Okay. So we have the vein. Within the vein, there's these processes that are called valves. What these valves are one-way valves. So the way that your body distributes blood to your system is these valves are one way. It can only go up. When it goes down, the valve basically closes. So if I'm doing a blind IV and I put it through a valve,
that's it'll be like in plumbing, that would be like backflow prevention.
Exactly.
Prevents the backflow.
Yeah. So like this is the best way for people to understand circulatory problems is related to plumbing because it's very similar.
So body's plumbing, yeah.
Body's plumbing, or the other one that we do a lot to explain, especially in Houston, because everybody's in the oil and gas, the way that you gonna dig for gas for petroleum. So if right before most valves, there's an area on the vein that becomes wider, right around the valve, usually before or after. Why? Because since the valve is one way, when it backs out, it makes the area immediately prior to the valve, it makes it fatter. So if you're going to do an IV, you want to put it right next to the valve with the cannula ending at that white part.
What is the name of that? What is it? Cannula?
Cannula. That's just the IV, the little plastic thing that goes in. So you're not able to see this blind. You can't see these processes. But if you're using the ultrasound, you can put it in such a way that the cannula is sitting in the widest part of the vein, all right, which is right here. So if you're able to put the cannula right there, the hemodilution.
Which would be what?
Hemodilution is just... So hemodilution is basically...
Keep the mic close to you. Like you can move it.
No, that's fine. So the hemodilution is basically the amount of blood to the amount of medication that is going in there. The higher the medication, if it's not diluted enough, that leads to infiltration. Infiltration is when the medication gets out of the vein and into the muscle. It hurts a lot, and it can detriment. It can really affect how wide the vein is. You could lose one vein, the whole vein, if you do an infiltration, and you will never be able to recover it. You won't be able to start IVs there. So when you do ultrasound IVs, you're preventing to that. There's antibiotics. They're called vesicants. They're called vesicants because they're basically like an acid, and it's the mode of action of how they destroy bacteria. But they also affect the vein walls. So, two things. If I increase the hemodilution, meaning I have an abundant flow of blood to decrease the amount of vesicant, which is like an acid that is in the vein, I'm going to prevent the walls from breaking and giving me an infiltration. The other key point here that you can do with ultrasound is the angle. If I put the IV like this, where the cannula is directly pointing to the vein wall, then you have raw antibiotic hitting that vein wall and causing something called turbulent blood flow. Turbulent blood flow is the medication goes in, it bounces here, it goes there, it bounces down, it bounces up. So basically, it's just hitting the walls you're trying to prevent. So when you put an IV with a sloping angle where the cannula is sitting in the middle of the vein or at the bottom, but without it touching the wall, then the turbulent blood flow doesn't happen, which increases your hemodilution, and it gives you a longer lasting IV. So that's how you can make an IV that normally will last for 2 weeks, last a month.
Guys, thank you for listening, watching. Please subscribe to the channel, and there will be more content coming soon from the channel.
The channel, the Nurse Multiverse. What we're trying to give people here is an easier way to understand disease process for the layman and understand how prevention is very important when it comes to your health.